Lower respiratory tract infection, part 1. In this part, we will discuss about bronchitis, bronchiolitis, and bronchiectasis. Lower respiratory tract infections are infections involving lower part of the respiratory tract, that is trachea, bronchi, and lungs. And these are the most common and important clinical problems that we encounter, and majority of the antibiotic prescriptions in developed countries and 20% of all medical consultations and over 30% of the lost days from the work are due to this lower respiratory tract infection. In developing countries, more than 20% of mortality in children under the age of 5 years can be attributed to acute respiratory tract infection. Clinical symptoms of lower respiratory tract infection include bronchitis, bronchiolitis, bronchiectasis, empyema, lung abscess, pneumonia, and pleuritis. General outline of laboratory diagnosis of lower respiratory tract infection. Specimen includes sputum, blood, bronchoalveolar lavage, and diagnostic methods include all the procedures starting from microscopy, culture, molecular test, immunological test, that is antigen detection, and biomarkers. And the relative importance of this test varies from syndrome to syndrome. Let us discuss about the bronchiolitis. This is a disease of children. This is mostly viral, and among the viruses, most common is a respiratory syncytial virus, and other viruses are human metapneumovirus, influenza, parainfluenza virus, adenovirus, rhinovirus, coronavirus recently added in this list. And among the bacteria, the atypical pneumonia agents like Mycoplasma pneumoniae and Chlamydophila pneumoniae. How can we diagnose bronchiolitis? Bronchiolitis can be diagnosed by antigen detection and multiplex PCR treatment. Antibiotics should not be used unless clear evidence of secondary bacterial infection. And hydration and oxygen is the mainstay of the therapy. Suction is helpful to clear the airway. Nebulized hypertonic saline 3% may be considered. Now, bronchitis less than 5 years, and another bronchitis is adults and more than 5 years. These are non-specific bronchial inflammation that usually follows viral infection, most common in less than 2 years of age. And isolation of bacteria from the sputum does not imply a bacterial etiology. Rather, it is colonization. It is also like the bronchiolitis, mostly due to virus, and the virus that causes bronchiolitis are also the same. They also cause the bronchitis in less than 5 years of age. Treatment of bronchitis in the young children less than 5 years of age. Here also antibiotics not indicated, and therapeutic oxygen is symptomatic therapy. Antibiotics may be needed if there is associated sinusitis, pneumonia, or pertussis. If antibiotics are started because of suspicion of sepsis, should be stopped if sepsis is excluded. And influenza should be treated in all children less than 2 years and in those who are in risk of hospitalization, even their age is more than 2 years. Routine use of bronchodilators are not effective. Now, bronchitis in the age group more than 5 years and adults. These are self-limited inflammation of bronchi due to infection or irritants. And here also, purulent sputum alone is not an indication for antibiotic therapy. Usually, these are also due to virus, but Mycoplasma pneumoniae responsible for 5%, Chlamydophila pneumoniae for another 5%, and Bordetella pertussis may also be a cause. How can we treat the bronchitis? Antibiotics are also minimally effective and not indicated, and patients should be counseled that cough may persist for 2 to 3 weeks. This is most important. Patients should be counseled that cough may persist for 2 to 3 weeks. Antitussive have limited value, and inhaled bronchodilators can be used but of limited value. Antibiotic use for some acute bronchitis is one of the most common inappropriate use of antibiotics, and reducing antibiotics in acute bronchitis is an excellent target for stewardship and quality improvement activities. অর্থাৎ ব্রঙ্কাইটিসে অ্যান্টিবায়োটিক ব্যবহার হলো সবচেয়ে একটা এক্সাম্পল, কমন এক্সাম্পল যে ইনঅ্যাপ্রোপ্রিয়েট ইউজ, এবং এটা টার্গেট করলেই অ্যান্টিবায়োটিক ইউজের অনেক ব্যবহার কমে যাবে, এবং এটা অ্যান্টিবায়োটিক স্টুয়ার্ডশিপের একটা লো হ্যাঙ্গিং ফ্রুট। এখন আমরা আসি ব্রঙ্কিয়েক্টেসিস। Bronchiectasis is caused by bacteria. এর আগে আমরা যা দেখলাম সবই ছিল ভাইরাল, এটা হলো ব্যাকটেরিয়া, এবং কমন ব্যাকটেরিয়াগুলো যেগুলা Haemophilus influenzae, Moraxella catarrhalis, Pseudomonas aeruginosa, Staphylococcus aureus, and rarely Streptococcus pneumoniae. Bronchiectasis culture is recommended prior to initiation of antimicrobial therapy to guide the drug selection. Usually, empirical therapy is not recommended. Let us discuss detail about the treatment. Yes, if the patient is not diagnosed as patient of caused by Pseudomonas, the etiologic is not Pseudomonas, then respiratory quinolones like levofloxacin or moxifloxacin once in a day per oral can be used for 2 weeks. Levo 500 milligram, moxi 400 milligram. But if Pseudomonas aeruginosa suspected and it is susceptible to fluoroquinolone, then dose is to be increased. Levo 750 milligram and Cipro also 750 milligram. Cipro 2 times a day, Levo 1 time a day, 10 to 14 days. Prevention. Long-term therapy for those with more than 3 exacerbations a year. Azithromycin 250 milligram once daily can be given for 6 to 12 months, 1 year. There are some other regime for prevention. Long-term inhaled antibiotic treatment is an option for patients who are intolerant or not responding to oral therapy. And although the benefits are not well established, the reference is given here. The preferred therapy is tobramycin, solution for inhalation. In 1 month on-off cycle, alternative therapy is nebulized colistin twice daily for up to 6 months or longer as tolerated. Initiated at the conclusion of a 2-week course of systemic anti-pseudomonal therapy. Reference is given here. This is the acute exacerbation of chronic bronchitis. Etiologies here, 20 to 50% are due to viruses and rest are due to bacteria. Of the viruses, respiratory viruses are the common: respiratory syncytial, human metapneumovirus, influenza, parainfluenza, adeno-rhinovirus, and among the bacteria, Chlamydophila pneumonia 5%, most important, followed by Mycoplasma pneumoniae less than 1%. Streptococcus pneumoniae, Haemophilus influenzae, and Moraxella catarrhalis infrequently. The thing which we must remember that tobacco use and air pollution are the main contributors for acute exacerbation of chronic bronchitis. Treatment, let us discuss about the treatment. For mild to severe moderate disease, no antimicrobial, or if or maybe amoxicillin 500 milligram thrice daily, doxycycline 100 milligram twice daily, Cotrim 1 double strength tablet twice daily, and duration is 5 days in all cases, not more than 5 days. For severe disease, instead of amoxicillin, amoxiclav 875 to 125 milligram twice daily, azithromycin first single dose, then 500 milligram single first dose, then 250 milligram once daily for 4 days, total 5 days, or 500 milligram once daily for 3 days. Clarithromycin extended release 1000 milligram for once daily, 5 days. Levofloxacin 750 milligram, moxifloxacin 400 milligram, both are once daily. For hospitalized patients with severe disease, if there is high risk for Pseudomonas to be confirmed by culture, levofloxacin 750 milligram IV or paroral once daily, cefepime 2 gram thrice daily, piperacillin tazobactam 4.5 gram IV 6 hourly. If there is low risk of Pseudomonas, levofloxacin 750 milligram IV or paroral once daily, moxifloxacin 400 milligram once daily, ceftriaxone 2 gram once daily. Prednisolone 40 milligram per oral for 5 days recommended for patients with COPD, exacerbations of more than mild severity. There is reference. So this is about the etiology, diagnosis, and treatment of some common lower respiratory tract syndromes. Thank you very much.